Hello everyone. A very popular healthcare system which comes out of United States is managed care organizations. In short, it is MCO. In this lecture or in this session, we will learn about these managed care organizations. We'll learn about the underwriters, as well as we'll learn about the reinsurance. So the first session, the first part of the session will cover these managed care organizations or MCO. MCO is kind of an array of services. It's an umbrella under which it covers all kinds of separate tentacles of this healthcare system. It has under its domain the hospitals, the clinics, the doctors, the pharmaceuticals, the diagnostic centers, the pathological centers, the even the health insurance companies. So everything is under a particular system, and with this array, so I will mention it as an array of healthcare services which is only provided to the enrolled members. So you have to enroll yourself, get a registration card or registration number through efficient management services. Now, in TPA we have learned that TPA are basically supposed to improve the efficiency of management services, reduce the time, reduce the cost, increase awareness flow or information flow. Similarly, the managed care organizations are also intended to make this entire health insurance healthcare system or health service delivery points together under the same umbrella, where there is lesser information asymmetry, lesser uncertainty. It's more connected, all the stakeholders are more connected to each other, better data flow, and all this. So through efficient management system. And the fourth is that the payment mechanism. It varies, from MCOs to across different kinds of MCOs. The payment mechanism varies, but at the same time, these payment mechanisms are also designed in a way so that we are, again efficiently managing that. When we learned about the pricing of our healthcare service delivery, we also learned that because of the multiple products, because of several choices, because of the several parts of a healthcare service process, there is ambiguity. There are always, so it's so complex, so difficult to measure a convincing pricing mechanism. Hence, if everything is together managed by a particular organization, these kinds of pricing mechanism are often better taken care of. So this payment mechanism is also very unique, what they try to target in MCOs. So it does not basically change the services, the service providers, the insurance companies, the pathologists, our diagnostic centers provide to the patients. So the service remains same, but the management, the referral, the time, the information flow, everything is smooth. And with this introduction of electronic health record, electronic medical record, in short they are known as EHR and EMR, that is health IT, introduction of information technology in these healthcare operations. With this EHR and EMR, so now you go to a corporate hospital, you will be given a number, and taking that number, not only in corporate hospitals, even if you are registered under a particular scheme, you are given a particular number, a government public health insurance scheme or any particular scheme, health CGHA, CSIS, you have a particular number, enrollment number, and with that enrollment number, now everything being in the soft copy, everything being in the system. So your information is reaching at no time basically across different service provider, not only even across the service provider when we are sitting in India providing service, as a BPO or KPO, we are providing service to the US healthcare market. Then based on the same number we are accessing the information of the patients who are sitting there. Some doctors are sitting here, some doctors are sitting there in US, and then we are trying to connect a network. So now again, having everybody under the same umbrella, under the same domain, of course have helped. Now there are basically two types of MCOs who of course the objective is cost minimization through efficient management practices. The two MCOs are, one, the most prominent one is HMO, Health Maintenance Organizations, HMO, Health Maintenance Organization, and two is PPO, Preferred Provider Organization. So HMO and PPO. Well, there is another one which is said POS, Points of Service, which is basically an amalgamation of these two. Some from HMO, some from PPO is featured in points of services. So these are the three basic MCO system what we find in USA, and the most two prominent one are HMO and PPO. So a registered HMO, so if we are now talking about HMO, Health Maintenance Organization, that any registered person with an HMO will, against a subscription fee, against the payment of a subscription fee, which is often yearly, they avail some services, and they allow the members, the HMO members, to access the data, access the employed providers. What they do, if I pay the subscription fee, I can avail the group of healthcare providers who are registered or empaneled under the HMO. But in HMO, one thing is little, unique, that or what is characteristics of an HMO is I cannot actually select my own practitioner. So what happens, there is always a doorkeeper who is a doctor, of course, who is a doctor, and I need to approach my doorkeeper doctor, and he or she will suggest me which way my treatment will go. So then there are several empaneled doctors, right? And she can or he can refer me that based on my health problems, they can refer me that which will be those empaneled doctors I can consult with. So after subscription fee, I can access those doctors, and then I don't have to make any payment to them. After I make a subscription fee, I go to those doctors, I take I avail any diagnostic system. These are free. Even a sort of insurance, this is a part of insurance because you have made a payment already. These are free, and after a certain while, maybe that depends, maybe you will be charged, but that depends. So over here, these health insurance companies, because they get the money from us, these HMOs are not health insurance companies, they just collect the money as a subscription fee, and then they connect the health insurance companies to insure these patients. Yes, they connect these health insurance companies. Now what these health insurance companies do, they are now getting a group insurance, because an HMO has a pool of patients, or a pool of, even if they are not patient, right? Every I can register myself under HMO even if I am not ill, right? That is the funda. So the health insurance companies now will be allured because there is a group insurance, and it's a kind of a mix of population, so there is no cherry picking either. So therefore the government also finds interest in HMO, and what they do, interest in HMO, and they find that HMOs are really doing a good job towards the society. And so what HMO does, HMO gets on from government is, one, they have a mandated market access, and number two, they receive a development fund from the government. And then the information share, of course, because the data the HMOs have, they share it with the government, and government can use the data for the research or their to improve their database. So this is all about HMO. When we talk about PPO, which is Preferred Provider Organization, PPO, the name suggests that as in HMO, I have to always go through a doorkeeper. In PPO, I can directly, once I register with a PPO, I have a list of doctors, and I can choose my doctor based on the proximity, based on the ratings in the internet, Google it, and then find, okay, this is the best doctor, so I will go to him or her. So they can choose it, and then the doctor, of course, have to be under this PPO mechanism. So here I have a freedom to choose my own doctor from a list provided by the PPO. Over here the subscription fee is low, but how the payment mechanism works is that I still need to make a payment to the doctors, which is lower for the PPO members. Lower means discounted. For the PPO members, this rate is discounted. So the PPO members enjoy a discounted rate. So because they have already because we have paid some amount of money to avail this, we can see in terms of, if you are aware of this Club Mahindra, they have a group of hotels, they provide services, the transportation services, the several other services in terms of a vacation, they plan the vacation, all this. So similarly, these HMOs and PPOs are also kind of, you pay a subscription fee, and then for Mahindra Group Mahindra is basically a Club Mahindra is basically a kind of a HMO in terms of tourism industry, but at the same time, this HMO and PPO is works towards the reduction of cost. But if we compare between the HMO and PPO, the cost is higher for PPO as compared to HMOs. So PPOs are expensive, than HMOs, because in HMO you are not paying anything literally after you get that registration card with HMOs. So but in PPO, every time you go for a treatment you need to pay, and it is increasing if you have to go for a multiple times, and for every service delivery you have to pay. So the what happens is that the rest of the money the doctors get from this from the PPOs, and the PPOs pay the doctors out of what the PPO members have paid as a registration fee. So that's how it works, So but eventually PPO themselves earn money by charging an access fee to the insurance company, and also from a little bit from us or from the patients. And why they charge then the access fee? Because what they get from us is lower as compared to HMO, so they have to make some money, and also they may have a nexus between the with the doctors. But with again, because HMO gives kind of a free access to the healthcare organizations, and they come for the group insurance. Here also the healthcare the HMOs give access to the health insurance organizations to get group insurance. Here also is the same thing, but PPOs charge the access fee for the database, or for the for the database of the population, of course, for their customers from this health insurance company. So I'll keep it like PPOs charge an access fee from health insurance companies against their customer database. Yes. And the services, these now points of services are basically the amalgamation of a combination of HMOs and PPOs. Like they charge, they don't have a subscription fee as such, so the POS also, under POS we also need to pay the doctor again a discounted fee, but at the same time in POS they have the gatekeeper, a doorkeeper, a gatekeeper doctor through which I can get access to the various other doctors. Anyways, the services what I get, from these managed care organizations are: number one is prospective services, number two concurrent services, number three retrospective services. Now, what is prospective, concurrent and retrospective? The prospective services are those which talk about first the pre-certification of a particular case, that whether a particular case will get insurance or not. It's a kind of utilization review. So I will keep it like of care for a particular case, and it is done by the utilization review. This utilization review is done before the patient is accessing the healthcare system, that is the hospital or something, or the treatment process, before the treatment process starts. So the utilization review is like my background checking, my experience rating or something like that. And the patients, so the utilization review starts before the hospitalization or starting of the medical care, and patients to be able to access as long as they are member of PPOs or HMOs. Access the healthcare. Yeah, so that it is also under pre-certification or utilization review, it is also checked that for how long the patient has been under this particular scheme, how long they can avail the treatment, what are the facilities they have availed, and and all this. So this is the prospective, before the treatment starts. And then there will be one personnel attached for a particular case who will look at the direction of the care. So directing of care. So which way it will go, like say the a particular gatekeeper or particular doctor who suggests that okay, you go to this HMO, you go to this particular doctor, or you go to that particular doctor, and then the referral starts working. You go to diagnostic, you go for this checkup, you go for some other doctor. So this entire networking is required to be managed well. So the entire process flow of their treatment. So and this is generally done by a designated person for a particular case. So this directing of the care starts just when the prospective services starts, so that after that, based on this pre-certification or the utilization review, the doctors decide that in which way this treatment process will move. The next is that there is a difference in case of direction of care. One is it's like for PPOs, and the other is for HMOs. So how it works for PPOs are very different than how it works for HMOs. We have learned that, right? PPOs, the patients choose their own preferred doctors. In HMOs, it is generally referred or recommended. In case of concurrent, as the name suggests, in case of concurrent, it is like a case manager, that particular manager, a case manager will look at the case, follows an individual case, throughout the treatment process. Yeah, so and now the treatment has started. So once the treatment has started after this utilization review, and the pre-certification, this the case manager takes the case up and then look how what has been recommended and how is it being followed. And then the first thing again under a concurrent mechanism of a MCO is utilization review. That checks the appropriateness and the quality of the care. Ness of the treatment. Yes, the next thing is pharmacy and supply materials and supply of different materials. Mostly pharmacies. So this means that what has been recommended, what kind of medications have been recommended, which kind of apparatus have been recommended, and whether it is being, excess is being brought, or there is a shortage, or if there is an anomaly, whether the during the process, if there is any shortage, or if something was required the previous day and it has not been there. So this pharmacy and other supplies, the other commodities management is also done by this case manager. And then the third is discharge planning. So once the treatment is at the last stage and the patient is supposed to be discharged, then the discharge planning starts, and then they will give the patient a discharge summary over where it will be written that what the patient is supposed to do, what kind of medications they are supposed to follow. Before the discharge summary, they will look preparing the discharge summary, they will look that what had been recommended, everything had been followed during the 5 days, 7 days, 1 day, 3 days stay under the treatment process, and whether the patient is okay to be discharged, because everything cannot be done by, if in case of a surgery the surgeon cannot do. In case of a particular treatment process where a senior doctor is doing, senior consultant is doing, it's not always possible to follow that up by that senior consultant. So it's then this case managers pitch in and do a fantastic job with their medical knowledge. And then the final one is retrospective. In retrospective, it is basically where the billing process starts. And in billing process, we generally have two parts. One is provider bill review, and another one is hospital bill review. Provider bill review is generally, generally the services rendered by the diagnostics centers, by the pharmaceuticals, by if there is the physiotherapists are coming from outside. So these are the external services, which had been provided by the healthcare provider, if not directly by the hospital. So that is the provider bill review. If that is provided by the hospital, because in MCOs all these components are separate but are connected together. So the hospital can be a separate entity, and these diagnostic centers, they are separate. They may not be under hospital. So their bill will be separate, hospital bill will be separate, and the combined bill will be prepared. So the provider bill review are those reviews, their bills, like say diagnostic center, pharmaceuticals, and all these things, where hospital bill review are generally by the hospitals. The salary or the consultant's remuneration, and if they would decide to mention that how much for these customary fees, the workers compensation, and all this, and how much are paid for the rooms for a particular service provided, a customary service provided. So all these are done by this under this hospital bill review. So therefore, when we have this, when we do this retrospective service, we are generally looking at this billing, because billing is the most common error under billing in a hospital scenario. The most common errors which appear is under billing. There can be the miscalculations causing losses to the hospital finally in every way. Or causing losses to the patients. If it is causing losses to the patient will give a bad reputation, or will carry a bad reputation about the hospital, and then they will never come back, or will give a very bad feedback. So the hospital is finally at the receiving end. So the billing errors are not be really intended for, and that is where these retrospective operations are done. Retrospective services are done by that case manager under an MCO, HMO, or PPO. Thank you.